Thank you. All right. Welcome everyone to our final sepsis work group presentation of 2024. My name is Emily and I'm one of the engagement coordinators with MVC. It's my pleasure to be facilitating this work group for you today. So to start, just going to go over a couple of housekeeping notes if this will progress. There we go. So first, this work group session is being recorded. The slides and the recording will be made available to you following the conclusion of the work group and that follow-up email. Just give me a little bit of time to put that email together for you. Next, we're going to be holding questions until the conclusion of the presentation. Our presenter has a lot of information to share with you today, and I want to kind of keep it rolling. But if you have questions that come up throughout the presentation, please feel free to add them to the chat, jot them down. We will have a designated Q&A session at the end, and we'll be monitoring that chat throughout the presentation as well. And then lastly, your feedback is very, very important to us. So at the conclusion of the presentation, we'll be providing you with that link to the post-work group survey, and we would greatly appreciate you completing that. As a reminder, for those hospitals participating in P4Pre, completion of that survey is mandatory to receive credit for your participation to this work group today. All right. So today's work group is going to feature a presentation by Akhil Vijay, or AK, from Garden City Hospital. AK is passionate about leveraging his expertise to enhance quality healthcare delivery, optimize operational processes, and ultimately improve patient outcomes. He completed his Bachelor of Nursing and Associates in Hospital Administration in India, and later finished his MBA in Healthcare Administration from Cleary University. He's currently pursuing his Ph.D. in Business Administration from the University of Cumberland, where he is completing his research on revenue cycle management. Over the last 10 years, he served as director, executive director, and administrator for long-term care facilities, chief quality officer, and director of operations for acute care hospitals. And currently, he is serving as the Director of Quality and Performance Improvement for Garden City Hospital. He's also one of the board of directors for the Baldwin Society, supporting older adults, helping seniors in his community. AK is going to be presenting for us today on Garden City Hospital's efforts to develop their hospital sepsis program core. And with that, I'm going to pass the slides over to AK for his presentation.
Thank you, Emily.
You're welcome.
Hello, everyone. Thank you so much for this opportunity. So today we are discussing about the first one I wanted to, this is a disclosure. There is no financial benefits by doing this for me. And all the data that I'm going to present today is completely from the Garden City Hospital. Also, the references are listed at the end of this presentation, and we will be sharing this later to you. And mostly, I used the CDC, ACHC, and CMS guidelines, and also publicly available research has been used for this presentation. So sepsis core measures, is almost like 9 years back around October. The CMS and Joint Commission actually launched this sepsis core measure for about 4,000 hospitals, and later this become actually evolved into the CMS inpatient quality reporting program, that what we call as the sepsis bundle, or as SEP1 bundle. It's the severe sepsis and the septic shock early management bundle. So I know that most of the team members here, they're already aware about the severe sepsis and the septic shock and the pathophysiology and what are the criteria. So we are not discussing that in detail. But just, for for the purpose of the presentation, we can just touch bases a few things like that. We know that there is a 3-hour bundle and also the 6-hour bundle. So for the severe sepsis, like either it's a suspected infection and also the 2 or more search criteria and any signs of organ dysfunction, which actually makes the sepsis criteria um, for the CMS reporting. And for the septic shock, it's a severe sepsis and any hypoperfusion or initial lactate greater than 4. And the physician documentation is important, or the provider documentation is very important in both these cases. So what are the actions actually for both the severe sepsis and the septic shock is like for your 3-hour bundle, you need to give your initial lactate, blood culture, antibiotics. And for it's the same thing for your septic shock too. But for your severe sepsis, repeating the lactate, if the initial lactate is greater than 2, that's for the septic shock as well. For your crystalloids or vasopressor for any hypotension, or repeating the volume status, it's not for the severe sepsis, but for the septic shocks. Your crystalloids, the criteria is within the 3-hour bundle, and the rest, the vasopressor and the repeating the volume, need to be met in 6-hour bundle. So we are talking about a lot of actually in our settings, we deal with the life, and it's a lot of commotion. It's a lot of team members are involved in this, and these are the criteria. Anything actually over the 6 hours, then it's not meeting the criteria. So then it's considered as a fallout, and that will be, coming back to the team members, and the hospital is not meeting the criteria, and then you falling out on your sepsis bundle percentage. So the burden of the sepsis, we know that it can be the source, there is a source of infection. It can be bacterial to viral, you name it. And these infections, if we didn't treat it well, this could actually cause any life-threatening, serious, deadly dysfunctions to your organ dysfunction can happen, and it can lead to severe sepsis and death. So most of the 1/3 of the hospital mortalities are from sepsis. About 350,000 hospital deaths and 1.7 million, because it's affecting a lot of organs. Dysfunction, this can actually lead to disability as well. Maybe a small infection, which could actually, maybe let's take an example of UTI, and if we didn't treat them appropriately, this could actually be a leading cause for a death within minutes. So some cases can actually take hours and hours, days. Some can take actually like within minutes. So we are when we identify the sepsis, the presentation, and those criteria that we discussed in the 3-hour and 6-hour bundles, the clock actually ticking, we have to actually jump on and take the necessary steps right away. Recently, we actually did a community event for this sepsis, and there were people were asking about what is this sepsis, and they know cancer, they know diabetes, they know heart failure and heart attack, but they don't know about sepsis. So the sepsis is always like a deadly shadow in people's life, the awareness in some of the communities is really poor. So this burden of the sepsis is really higher. And that's the reality in the community, the social vulnerabilities. And then it comes to our hospital, then we have our staff that we have to take care of it based on these CMS criteria. And if we are even like 1 minute over, we are falling out of this criteria, which affect our sepsis bundle benchmarks and percentage of compliance. So that's where the CMS actually came up with this evidence-based, value-based approach, right? Like not only just the patient quality, how can we provide a feasible quality care with a affordable cost. Within the affordable cost, how can we provide a good quality care for these patients? So just the quality as well as the cost. Both of them needs to be balanced each other, and that's where this evidence-based practice. So they put these landmarks, they put these guidelines, and like they are asking the hospitals to stick to it, follow them. So that's the way they can monitor the data, how we are actually taking the necessary steps to meet quality, and also how we are controlling the cost as well. So these are that's where we are actually in the hospital. In these situations, we are the hospital leaders or the hospital administrators or the quality administrators or PI coordinators. These are some of the challenges that we are going to face. And, even before COVID, staffing was always challenging. Healthcare workers, there are multiple areas. It was really short and thin. And after the COVID, it became, not better. And it went down, and it made a more difficult situations across the nation. Healthcare workers shortage. And then the existing healthcare workers actually trying their best and they get burned out. And then, the turnover rates are really higher. So when you have the higher turnover rate, and did I lose anybody? Emily?
Here. We're here.
Oh, so sorry. It was showing that Jessica was talking in my computer, so I just stopped it. Sorry. So basically, this healthcare shortage across the nation affected, and this turnover rates. When it's the turnover rates, it's nothing new. We all knew, we all been there. We cannot implement, we cannot educate, we cannot train our staff, we cannot have a consistent group of people who taking care of the patients every single day, who actually who actually have the knowledge of the policies and the procedures and the benchmarks and why it is there. Why is the reason? I'm a person actually always love actually to know why behind everything. Then when I do it as a nurse, I was always eager to know that why am I doing it? Like when you do something with the sense of a purpose. Knowing the sense of purpose behind it makes it much more easier. And that's one way that we can empower our staff too. But unfortunately, the staffing shortage and also this turnover rates, which actually been a great challenge for the hospital administrators and the quality directors and the quality team. And this is that's where when I joined actually in Garden City in January and February. And my first initial project was the sepsis. And we always been in a 43-46% was our compliance rate. And then, I was taking the first quarter report to my governing body. And my governing body committee members, actually leadership team, asked me like, why is this always like a trend of a 40%? Then that's where we had actually our hospital leaders there, the CEOs and the CNO and CMOs were there. And so the chief of staff was there as well. So, we told the governing body that, okay, let us actually look deep dive into it, and let's do the root cause analysis, and let's see that what exactly is the problem and how we can actually mitigate this issue. And then we came back, and the first thing is this hospital leadership commitment. We are blessed to have a great CEO actually who really is into the quality, and he invests actually more time for the quality. And the CNOs and the CEO, you need them. as well as your CMO and the other physician, medical directors, your chief of staff needs to be actually have a need to buy in what you're gonna be implementing in your hospital if you are coming up with a hospital sepsis program. And we were blessed and we were very, very fortunate to have this good team, and they were very supportive of this one. That's the second problem was accountability. Like, if we are talking about 1,135 employees total, where in addition to that, we have 400 physicians and 92 resident physicians. We do have ACGME programs. So we are talking about almost 2,000 people. And initially, I felt like I'm like I don't have any control, like oh, there's a problem going on here. Okay, the blood culture was not collected. Okay, so it's the nursing issue. Oh no, actually the lab didn't result it. The lactate at the right time. Okay, so that's a lab issue. Oh, the resident physician or the ED physician actually didn't capture the sepsis initially, and now the hours are actually passing by. That's another fallout. So it's like how are we going to do this? And that's where me and my PI coordinators actually we internally discussed. Every Thursday morning we have a quality stand-up meeting, and we actually bring cases from Blue Cross Blue Shield, the P4P, the HMS sepsis cases, as well as the CMS cases. We try to diagnose ourselves and to see that what's the problem and what's the trend? Is there a trend? We try to do the root cause analysis. Then how we can actually hold them accountable is like we tried to discuss that, and that's where we came up with okay, including the multi-professional expertise. It's not just one man game, it's a team effort. So the first thing was like we discussed with our hospital leadership and asked them, because they've been here for a long period of time, who are the key players, who has the interest, and we came to know the people who are interested, and then we send out messages to the resident physicians across the border, especially the emergency medicine, the critical care, and the internal medicine. We ask them like, hey, who wants to be actually part of this? If you like to write a paper and publish anything, like try to empower them, because they don't want it to feel like we are taking advantage of them within their busy schedules, but at the same time it's a mutual benefit. So they were happy to join and bring more ideas, instead of the quality team telling them that, hey, this is going to be the structure, this is how it's going to be running. We didn't say anything. We just asked them, like, tell us, like, what are the problems? Tell us, like, who should be there and what should be the role definitions. Once we hear from them, we took it back and we came up with we had a written plan, and we came up with a committee members, and then we came up with what are we actually going to look into it. We reviewed, I think, in February, almost like 2023 whole year cases. We put it in an Excel sheet and we looked into like what are the common fallouts. Is it blood culture? Is it the lactic acid, or is the second repeat lactic acid, or your crystals, or where is your issue? We try to do a root cause analysis and identifying the trend. Then we came up with the benchmark internally. This is the goal we are going to be as SEP 1 was also a beast. Is that sometimes like the nursing team doesn't know about this, resident physicians doesn't know about it, lab doesn't know about it. Another one struggle is the lab, because nowadays the lab technicians and the lab personnels, like certified lab professionals, to get them, it's really hard. It's getting slim and slim and slim. So when you have the new team members, you have to teach them, coach them, and make them understand why are we doing this, and how it is impacting the life for take life-changing decisions for the patients. So all this needs catered, and so and through what we did was like an interdisciplinary team. We called them together and told them that, hey, this is what we were able to find from our data quality department. These are the data that we got. This is the result. This is the trend, and this is what you proposed, and this is what we are proposing. And then we find a medium balance, because we need to understand also that most of the physicians, they not just practice here, am I right? They actually go to different facilities. They have their own clinics, and sometimes these resident physicians, they actually work on multiple research and their own studies, and it's a really time. And in between, honestly, we in every single team, we have actually our slow stars, steady stars, and superstars. Am I right? So we have there are people who doesn't want to be participator, who are like, okay, I'm gonna come to this meeting. I'll be just there because I need an attendance. I could use that. There'll be some people like, genuinely care about, like, go beyond and above. They literally wanted to see the needle moving in the right direction. So we understood those three different categories of the people, and we always actually try to show them this is black and white. This is the data. This is actually the where we are falling out. So from that, we came to understand that, okay, let's do sepsis committee meeting every single month, and let's do actually a fallout review of cases, different cases. And we gave the opportunity to some of the resident physicians as well, and working with our program directors of the graduate medical education. Resident physicians were called in to present some cases, so their active participation was there. And then it's a teaching hospital, so the physicians were so thrilled to teach the residents, physicians as well, like, to show them that, hey, this could have been actually chosen another different pathway. We could have saved time here. This is actually an unnecessary cost. We could have reduced this. Then we also included this in our utilization review meetings. So the reporting trends, actually, we once we came up with the benchmark, the next thing was like, okay, now we know the problem. We got the buy-in from the physicians. We got the buy-in from the leadership team. Now we have a committee. Now we have the time. Now we know that an agenda to do it, the fallout review cases. Okay. Now where to report it, and how actually, who should be actually, spearheading this. So that's where, our sepsis coordinator and myself as the director of quality, like we both actually, started to take these things to every single meetings as possible. Possible. Like, for example, every Wednesday we have didactics for our resident physicians. So we started to present the cases there. And this is one of the requirements for the ACGFME for mortality and morbidity review. And so we gave the cases for them to review. And it's about, like, from literally from two resident physicians attending to last month, I was able to see almost like a 30 to 40 resident physicians were packed up in the ballroom for this meeting. And I was so happy to see that the cultural change by empowering these resident physicians and the staff. Another one thing is also about the nursing and other lab and pharmacy. Am I right? They included this sepsis in our their competency list. So the annual competency review. We started to actually educate them, and we started to actually do a rounds, our infection prevention and our antibiotic stewardship person and myself. We actually do multiple rounds to the different departments, and then we ask questions to them. Then we give them small treats, and as a positive reinforcement. So we're trying to conditioning the behavior and changing the culture from just doing to this is the reason why I have to do it. So from A to this point, like we were able to move that culture. And then we strongly believed that education is the light in the darkness. The literacy is very important, and education is much important. So we always actually focused on keep educating instead of actually going after them or pointing down a department or putting them down. We always actually like, hey, this is a great you did it's like a sandwich model, like in between the two breads there, we put some meat and like a lettuce, am I right? The same way, we tell them like, hey, you did actually A, B, C, D. This was really great. And the patient came with the presentation, you identified it, you you used the sepsis order and everything was great. But here is a small problem. We missed this opportunity. Can you work on this? And how about we can do this? If there are some cases actually like a really concerning, then we take them to our internal peer review. And we have external peer review as well. And in the internal peer review, our CMO is the chair and the staff is the co-chair. And myself and the med staff will be are there. And then we actually do the FPP, OPP, all those portion. And we incorporated a sepsis into this. And we started to send letters to these physicians saying that, hey, you had a fallout, and we just wanted you to know this is not anything like for a penalty or a punishment or anything. We just want you to know that our peer review committee, we reviewed, and there is these are your scorecards. So that was another one thing, like resident physicians, and our nursing staff started to take it like a competition. And they wanted to do better for their department, and they wanted to, and it was funny, like internal medicine resident physicians and the general emergency medicine resident physicians, they started to have a competition, like who will do better. And the critical care team was like, they wanted to bring the best outcome. So it was like a really good to see that competition. So we always wanted to make sure that it's a healthy competition. So that's how our hospital sepsis program evolved. And these are the things just that I actually don't want to talk more and make you like bored. So I just felt like, to like talk like a story. Um, um, then we already discussed about the leadership commitment. Accountability is something very important. One thing I learned was like, things are really going great. Let's stop it and let's focus on another thing. No, still we have to actually trust and verify. And because we are human beings and we have a lot of things going on. And so we can actually have misses. And it's always good to have the quality control, pulse check, and multi-professional expertise is like we always actually open the door for different physicians to come in. We have only two physician champions, one physician champion from the critical care unit and one physician champion from the emergency medicine. And our chief of staff is actually the program director for the internal medicine. So they three are in the sepsis committee, but we encouraged other um, expertise to come in as well. Um, we even included actually our nurse assistants at one point to just to they need to know as well, like any vulnerable changes, how they can communicate. Then what are the barriers? The barriers are like we are dealing with a human being, right? So there will be, of course, there are moments where, um, first of all, we discussed about the staffing shortage. It's definitely going to hurt us, that thin lean management. Some of the hospitals are not have the opportunity to have a specific sepsis coordinator. That's really a tough one. And I'm one of them, like our hospital. Because we are a standalone hospital in Michigan, even if we have 53 hospitals all around the nation, most of the hospitals are in California based. So we are only two hospitals here. We are so we have to be creative. And how we became creative was like we have a data quality department and a CDS department. So we what we used to them is like using their skill set and requesting them to go to the bed meetings, and being open about the live cases, the live sepsis cases, like, hey, these are the problems, these are the fallouts. So the PI coordinator will be there as well. And then we try to tell them that, hey, these are the fallouts, why we cannot actually address them. So the next time, please address the issue, or if the patient is here, please go ahead and address this issue. Then we have a corporate a data quality team and a value-based purchase team as well, VBP team. So they actually send us Excel sheets with live cases, and we actually look into those cases and see where is the fallout and who is the person responsible. Then we send emails to those disciplines. It can be a nurse, it can be a lab, it can be pharmacy, it can be a provider. So we alerted them and we expected them to give us a response back. Unfortunately, we don't. And we all know that because we are busy. But we actually, that's where the accountability comes in. We bug them again and say that, hey, just following up on this email, hope you are doing okay. Can you please let us know what's the status and what happened? What could do it better? And eventually, it's like a tug of war, but it never should be like a penalty. They shouldn't be feeling like we are aggressive, but at the same time, they feel like we really care, and then they slowly started to be on our side. Trust me, there are moments where I felt really like, Lord Jesus, what am I going to do? But there are moments where it actually, the team, we have to do the best for our patient. And that's why the reason we are here. And that helped us to move every day. And another one is the meetings. There will be a lot of challenges because the physicians might be called for code blue, because rapid response team is basically, some of the physicians are involved in the rapid response too. So when they go in, but we still continue to do them and we update them. We never skipped our meetings. And in fact, like the last month was a sepsis month because it was September. It's a sepsis month. We invited a physician from University of Michigan working with HMS before P, and they were giving some great feedbacks to our resident physicians and our team. So the performance in another one thing was that, like, in the job description, so we tried to incorporate the sepsis in part of the job descriptions as well. And we revised that our orientation, we changed a few things in our orientation. And one another area we understood was the physicians were not using the order sets, they being a little organic. And we tried to tell them that, order sets are there for a reason, and we would have really appreciated to use that. And that actually tremendously helped us actually, honestly, this using the order sets. There is a system in place, so everybody started to follow that. Then the regional support, we discussed about, we have 53 hospitals, and these hospitals have a director of quality and CNOs and physician champions and policies. So we were able to reach out to them and get those policies. And then some of the hospitals actually do code sepsis. And we discussed internally here, like, can we do code sepsis here? And later we came to understand that, there will be a lot of codes. Right now it's of almost like we have like a 23 codes. So it's going to be a lot of codes. Rather, like we continue what we do in the fallouts and communicating with the appropriate discipline and taking necessary steps. That's what we continue to do it. Then any external training that we can do, any internal training, any fun events that we can do. Sepsis. I strongly believe that I somewhere read like if it's like you can, if it's more than 53 times, if you tell somebody something, then it's gonna be registered in their mind. So that's our goal, like more than 53 times if we can say, we will still we still continue to say that. Um, then we already discussed about all these areas, accountability in multiple interdisciplinary team, ensuring the flexibility of the treatment. That's something some physicians are having their own treatment modalities, and they are really they wanted to do that way, which sometimes can be challenging. And That's where the evidence-based practice, involving the CMO and having conversations with them helped us. At the same time, involving pharmacy and because especially this uh, microbial stewardship, when you don't give the antibiotics in the right time, and the pharmacist is saying that instead of giving this antibiotic, this patient might benefit from another antibiotic. Sometimes, physician can actually have a hesitant to it, but our pharmacy group is actually having a good relation. They were able to establish a good relationship with the physicians, and that flexibility and open mind was able to create, but it was not there previously, but now we were able to achieve that. And we discussed about the hospital order sets. That's one key important thing. Like some of the hospitals or sister hospitals have like check sheets or cheat sheets. Like they have like a flow program. Like we can actually do this one. We had that one, and we eliminated it. We want everything in our EMR. We want everything to be followed here. But for the new staff and the new resident physicians, for their learning purpose, we still provide those sheets. Every July, we get the resident physicians, new resident physicians, and we blocked their time to educate the sepsis program as well. Then we already discussed about the antimicrobials. Then we are right now thinking about the next year, adding a pharmacist, if it's possible, or moving the location of the pharmacist closer to the ED and more accessible to the staff. Now it's like they have to call the pharmacist, and it's like a little bit more convenient if we have the pharmacist available in the ED. That's something that we are working on right now. And some of the microbials are available in ED, ICU, and areas. And we are educating our staff consistently that you cannot miss the antimicrobials, because that first antibiotics that you are going to give it to them is going to save the patient's life. Most of the death, actually, most of the mortalities happen from the sepsis is because of lack of administration of antibiotics, the first antibiotics.
AK, I hate to cut you off. We're at about 12:40, and we
Okay.
had a couple of questions come in through the chat, so I just wanted to make sure we'd have time for that.
Yeah.
I believe you had a couple of slides at the end that you might still want to go through.
I think that we are towards to the end. I can
Okay,
probably finish them in 2 minutes.
sure, sounds great.
Okay.
And then we'll get to questions.
Awesome. So this is like another one thing we faced a challenge initially was interdisciplinary team. The interdisciplinary team through the ED throughput, we initiated another meeting, ED throughput meeting, where we started to discuss about like what are the problems from the ED to other floors. And the handoff was another issue because from the ED, the patients that go to ICU or any other different parts, sometimes this is not communicated. or they forget. So that's something like we are on top of that through this ED throughput and our fallout cases. We actually again bring sepsis there, even if in ED throughput sepsis shouldn't be actually bringing it over, but we made sure that wherever we can bring sepsis, we try to bring the sepsis there. Then we educated our rapid response team. Readmission, we've been closely monitoring and we report this to the medical executive committee and also our utilization review, where most of the chief physicians are there. That helps us actually to move the needle. And tracking, we have an internal tracking system and we use the data quality teams supported to track the data. And we discussed about the sepsis committee. These were the initial fallouts we had. Fluid administration, incomplete vasopressor, missing blood culture, inappropriate antibiotic administration, or not a complete administration, missing initial lactic acid, no blood pressure reading, within 1 hour of your crystalloids. So we already discussed this as well. I want to show you. So we actually started before this past year, we were like a 43. One month it was like a 33%. And we are trying our best. Now we can see that, we are at the consistently in an average of 60%. And we know that our goal is 100%, and we are trying our best. And I strongly believe that our team is going in the right direction, and we are still actually looking for any feedbacks through these work groups. And thank you for the MVC to arrange these meetings, because we get a lot of upcoming MVC meeting as well. Those are the platforms where we can get more ideas, anything that we can get to improve and provide the best quality care for our patients. That's all. Thank you so much.
Great. Thank you so much, AK. Very informative and detailed presentation. We did have a couple of questions, like I mentioned, come through the chat. And I think you might have briefly touched on some of these notes, but maybe if you can provide us with a little bit more detail. So the first set of questions are which EHR platform are you using? And are you using order sets for your sepsis bundle, which I believe you mentioned using order sets? And then sort of a separate question, are your physicians hospital employed or mostly private? So would you mind, is there anything you'd like to add to the note on the order sets that you're using?
Yeah, we are using Epic, and we do use order sets. And as like I said, order sets we are not using previously. It was inbuilt and it was old, and we have to work with our Epic team to modify the way that how we want it to be. Even if there is a sepsis bundle that we are using, we have to still make sure that our operational flow is actually in alignment with what we can achieve in compliance. So it's not just like the previous one was completely the sepsis bundle and with a very slim directions. And now our Epic team actually was like holding our team more accountable through a good revised set of order sets. And to the second question, we do have actually a lot of contracted vendors. Our ED is contracted vendor. ICU is contracted vendor. That's actually a great question. That's again, kudos to our CEO, because he mandated that every single contracted vendors should have a quality indicator closure. And that quality indicator closure will have certain criteria, including sepsis. And that is the benchmark that quality, that contracted vendors needs to, meet the compliance and need to report it to the quarterly quality committee meeting and I have to take that to the governing body meeting and the MEC and medical executive, and then to the governing body. That's how our CEO put the system in place. And that actually really helped me because I don't have to fight. I don't have to ask for it. All I can say is like, you signed it. As a
Mm.
contracted vendor, you signed it. This is your contract. This is your quality indicator measures that you agreed that you are going to be in compliance.
Yeah.
So they actually follow that, and that helps a lot.
We had another question regarding the order set. Jennifer asked if you knew what your sepsis order set usage rate was. Do you
I
happen to?
don't. That's a good question. I should have actually included that. That's a, did you see? I see. I told you, like, through these meetings we get every time something
You
like,
get some new ideas, right?
yeah, yeah,
Yeah.
definitely. We're gonna look into that.
Wonder if that might be, kind of an additional aspect of your tracking that you're doing.
Yeah.
Okay, great. Well, Allison had another great question for us. They're wondering what strategies has your team used to help with accountability for the providers? I know you mentioned that accountability seems to be a very important piece of your puzzle.
Yeah.
So what strategies? I know you mentioned a couple. I would maybe ask maybe the top two that you think seem to have been most successful with
Yeah.
ensuring accountability.
I will say that, physicians are the highest educated professionals when we sit on a table,
Mm.
in any meeting. And sometimes it's really hard to work with some physicians and to have their buy-ins. Then give time and then work with the CMO and this chief of the staff. We actually changed a few physician champions from our committees because they don't match with our core values or where we wanted to go. So we changed them, and we finding the right person and as a cheerleader will help, who is approachable. We can text anytime. We don't initially I had a difficulty, like I have to text the physicians to come to this meeting 3 different times, 4 different times. Now actually, like, I don't have to text. They know that, oh, this is the meeting, I have to come, they will be there. The physician accountability, the second, so one is changing and finding the right physician. If you don't have the right physician, the second thing is, like, what I did was, like, I put a lot of weight on me. I actually got them. Yeah, they like actually the Dove chocolates, if that works. I don't know. No, actually, few physicians asked for chocolates, and I got them chocolates. I'm seriously saying, they work, and when they come for this meeting, it's like our EMS, like when they come to the ED, they don't have the time to sit and eat. They just grab from something and they go. Like that, I got them food and drinks, and make them like more personable, trying to know them, and uh, yeah, and it was a little difficult initially because I am a nurse by profession, and now you have to establish a relationship with your physician in such a way that you are more like a professional friendship where you collaborate together to work, and involving your CMO is the another one thing that's sometimes hard conversations that you cannot have. You can still actually, tell them in a very polite way. I always use this way though, like in some meetings, like I tell them, and again, this is kudos to my CEO and the CNO because they have my 100% back. And even in MEC or governing body, I tell them that, doctor, I completely agree with you, A, B, and C, but I politely disagree with you. I use the word politely disagree. to tell them that, I disagree with you. So your CMO and your leadership team needs to, and initially it was really hard for me. I had to take a lot of pampering, hand holding, chocolates, water, spending time with them. But once they know them, once they trust them, once they see that, oh, you can move the needle, oh, you can trust this guy or this department, they will start to work with. That's what I see. Yeah.
Great. We had one clarifying question come through with regards to the contracted vendors for the service lines. They just wanted to clarify the service lines that you had mentioned. Was that emergency and critical care?
Yes, ma'am. Yes.
Yes. Okay.
And also hospitalist group.
And the hospitalists. Okay. All right. So emergency, critical care, and hospitalists are all contracted service lines. Okay. Great. Let's see. I'm seeing a lot of comments. I think this was in relationship to creating relationships, positive relationships. This is great, impressive work on identifying the right people for your physician champions. Irene said, thank you for sharing. I can relate to the many challenges you've worked through, as well as the excitement you shared feeling when progress was made. I feel like you're telling my organization's story through the sepsis journey. Thank you and great job. Excellent work. Joy said she also hands out treats. So apparently chocolate is a
Chocolate
common
works.
thread here. She said it's made a ridiculous difference, and people now willingly talk or seek me out with their concerns. She was wondering, do you meet in person for your meetings or do you meet virtually or maybe a combination?
Absolutely. Any time, and these collaborations definitely help us,
Yeah.
yeah, come up with the new ideas. Like right now, I never thought about the percentage of usage of this order set. That's just something like now it's in my brain. We need to go and look for
Great.
it.
Are there any other questions that anybody would like to ask out loud or send into the chat? Can I do one more call and then I'm just going to finish us up with some reminders about upcoming events. Go ahead and share. Okay. Great. So thank you so much for your presentation again, AK. This does conclude our sepsis work group series for 2024, but stay tuned for the 2025 work group schedule. That's going to be coming soon, hopefully late October, early November. As a reminder, to achieve the 0.25 P for P engagement points for attendance to this work group series, your site must have had a representative attend all 4 of the sepsis work groups, participate in at least 80% of each of those sessions, and then complete the post-work group survey. I'm going to have Rachel drop the survey link in the chat right now. That will also be in the follow-up email if you're calling in or just unable to grab that link right now. All right. So kind of upcoming events. For those of you that are registered, we have our fall collaborative wide meeting coming up on October 25th. That will be at the Vista Tech Center in Livonia, Michigan, from 10 to 3. So I look forward to hopefully seeing some of you, if not most of you there. And then we will also in early November have our last preoperative testing work group. That'll be on November 5th. With a presentation from Pam Ratchie from the Michigan Surgical Quality Collaborative. So we look forward to hearing a little bit more from her. All right. We have that link in the chat. I honestly can't see. Yep, it's in there.